look at
Just
that
look,
one
just
right
look.
there.
Now look at this. You're live. You're live.
look
You
at
are
that one.
live.
Okay.
Welcome everyone. Welcome to Security Tales. So listen up, everyone. Everybody knows, obviously, it's Security Tales, and we're on. Today's episode is an important one. March is Colon Cancer Awareness Month, and we're taking the time to talk about something that many people avoid discussing, but absolutely shouldn't. Do you hear me? Colon cancer is one of the most preventable cancers when caught early, yet thousands of people are diagnosed every year simply because they delay screening or don't recognize the warning sign. That's why today we're bringing in the experts. Once again, joining Dr. Huang, Dr. Lindsey Channen, and Dr. Arpan Patel.
That's good.
I
said
said
that
it
sounded
right.
pretty good. I liked it.
Two physicians who specialize in gastrointestinal health and cancer. So thank you so much for joining us today, everyone. I appreciate it. So, doctors, thank you both for joining us. And Dr. Huang, thank you so much for inviting them today.
Thank you for having us.
Thanks for having
So let's start with questions and what's going on. So would you like me to ask you questions? But I'm not going to lie. One of the questions need to explain who you are and what made you go into your field. So
good questions.
Ladies first.
So I'm Lindsey Channen. Obviously, we're both gastroenterologists, and it's not necessarily a field I saw myself going into when I originally started going through the process of choosing a medical specialty. But I think one of the things that really drew me to gastroenterology, it's a fairly male-dominated field. And I think in GI, we talk a lot about a lot of sensitive issues regarding women's bowels and things that people don't feel particularly comfortable talking about. So I like being sort of a safe space for women to be able to come and talk about those issues with. And it's a really great field where we're able to sort of combine a procedural specialty with a lot of really innovative medical treatments as well. So those are some of the things that drew me to GI to begin with.
My name is Arpan Patel. I'm also a gastroenterologist. What drew me mostly to GI was the combination of procedural and clinical medicine. I think I find myself as somebody that needs some excitement on a regular basis. And so I like the variety that GI provides, whether it's seeing patients in the office, doing screening procedures, doing hospital-based procedures. And so that was the biggest draw, is that you get a longitudinal relationship with patients, and then you get to take care of them in both a clinical and a procedural capacity.
All right. Love it. How about you, Dr. Huang? I know you've been on many times. Can you explain to everyone your background and your knowledge and how you associate to this? Don't look at me that way. Don't look at me that way. Go ahead.
So my idol growing up was Dr. Quinn, Medicine Woman. I don't know. You guys know.
They're kids, Dr.
So Jane Seymour, she was like this doctor in the Wild West, and she did everything. Like she would like deliver babies, and she would like if someone fell off a ladder on the farm, and like she would like be that person, like just take care of everybody. So I was like, I want to be that person that knows a little bit about everything. So that's why I love family medicine. I want to be that like go-to and jack of all trades, master of none. And then I have people that I know to send them to when they need more specialty care. And then I like to add a little procedures. We do a lot of little procedures in primary care, not like colonoscopies, but like skin biopsies and stuff like that. So I like to work with my hands too. So it's a good mix. So, and then the longitudinal aspect is great too, working with families, generations in the same practice. Like I have multi-generational, like 3 generations of families. So it's great.
All right. Great. So let's just get right to it. All right.
Sure.
So what exactly is colon cancer, and why are we seeing so many cases today, even in younger people?
So colon cancer is, as the name implies, cancer of the large intestine or the colon. It's an abnormal growth of cells that have the potential of metastasizing. It can be life-threatening in many patients. The rates of this are rising as, one of the things we'll probably address pretty prominently during this podcast is that it's now the number one cause of cancer-related preventable death in the United States, especially in patients under 50. We're finding a lot more cases of colon cancer. There have been changes in guidelines over the last decade where we used to screen patients at the age of 50. We're finding younger and younger patients that get cancer at earlier ages, and now the screening age is 45. And Lindsay can talk a little bit more about why we may be seeing that.
Yeah, and I think to the question of why this is that we're seeing so many young patients that have these diagnoses, we don't know exactly why it is, but there's certain things that we know to be risk factors for colorectal cancer, things like obesity, eating a lot of processed food, a low fiber diet, things like this. And so we do know, sort of based upon statistics, each year it's increased about 1% the amount of patients that we're seeing under the age of 45 with colorectal cancer. And that seems to be increasing exponentially. I don't think there's one particular reason that we could necessarily point our finger to say that that's what the reason is. I think part of it may be as well that we're doing a little bit better job screening these younger people and selecting patients who we see may be higher risk to develop colorectal cancer and kind of capturing those patients at an earlier age. So in some sense, I think part of it is that we're doing a little bit better job at screening people as well.
Okay, great.
Can you move the camera so Dr. Patel's more on Lindsay's?
Hold on, I gotta move the camera, everybody, because Dr. Huang just told me I need to move the camera. So hold on. Is Dr. Patel in it now?
Yeah.
Yes.
How about you, Dr.
Yeah, I
Huang?
don't
Are
need
you in
it. No, it's okay.
Hold on,
I'll just do this.
You
Okay.
kidding me? After you've had that beautiful facial today and everything?
No,
you
that
gotta
was
show
you.
beautiful
Mine
face?
was last week.
Oh, I'm sorry. So, Dr. Wang, before you scolded me to move over the camera, I wanted to ask you this. So you being primary care physician, and obviously you do a lot. You see everyone for everything in there. So what have you been seeing that affects this? Have you been seeing a rise in your patients and stuff with this?
Well, I wouldn't be the one who like makes the actual diagnosis. Like these guys are the ones who like do the the procedure, get the biopsy, and all that. My job is more like to encourage people to get there. So my biggest frustration is getting their head wrapped around the age 45. So what I do is I start having the conversation like at 43, and I'm like, okay, let's start planting the seed. So like when they're 45 and then come in, I'm not like, okay, you need a colonoscopy, and they're like thinking about it, and then by the time they actually go, it's like 2 years later. So I feel like my role in this whole prevention is to start talking about it at an earlier age. So at 45 they're going.
Okay. So Dr. Alpin, when I just realized something, you just said to me that the screening process is now the age has dropped, and you had stated 45 now.
Right.
So one of my questions is, I was going to say, at what age should you start? So you're saying it's 45. I mean, unless symptoms or something might show up. Like, is there something like?
Yeah, so I mean, I think 45 for low risk individuals that have no symptoms. And when I say low risk individuals, we're talking about patients that don't have a family history of colon cancer or advanced polyps in first degree relatives. Now, if you have multiple second degree relatives, that can influence your risk as well. But the primary thing that we're looking for are patients who have a family history of colon polyps, patients who have family history of colon cancer, especially. Those are patients that are typically higher risk. And so in those patients, they're often screened a little bit earlier, usually at the age of 40. Okay. Now, if you have symptoms, colon cancer the challenge with colon cancer is a lot of times it goes undetected for a long time because patients don't have symptoms. Now, some of the red flag symptoms or concerning symptoms would be, weight loss, changes in stool caliber. So if all of a sudden now you're having like pencil caliber stools or very skinny poop.
You have to explain.
You gotta bring it down. Some of my followers that don't use things past two syllables.
Skinny poop. Pencil was 2 syllables. Yeah. Pencil was 2 syllables. So
no, he used another
pencil
word.
Thin. He said pencil thin.
Pencil thin, yeah.
No, there was another word before that.
Stool caliber.
Caliber.
All right. So if you have skinny poop, if you have some weight loss and you're having some rectal bleeding or blood in your poop,
blood and poop.
You got that, my people? Blood and poop.
Those would be reasons to get this evaluated a lot more. Early. I mean, a lot of times bleeding in the poop could be related to hemorrhoids and other things that are not related, but there are a lot of patients that will have potentially polyps that are caught incidentally, even if they have hemorrhoidal bleeding. So
wait, it's time for a joke, but you don't want to assume. Thank you for laughing.
Yeah. Lindsay's not sure what to make of that.
Right. Yeah, no. I'm sorry. Yes, we let Dr. Wang make a point.
But in all seriousness, can I segue onto what he said?
Well, I was going to ask Dr. Channen something off that because I've noticed that Dr. Arpan has basically brought up history of family, but I found it interesting that when you had spoken, you had talked about nutritional factor, about the way they eat in foods that they've intake that possibility could cause it.
Mm.
So I got kind of confused. So we should be looking at both of it. Diet and nutrition is the main factor of it. So would obesity change that up?
I think on the one hand, and not to like lead to any misconceptions, obesity is a risk factor for development of colorectal cancer, but there's no specific diet that anyone could really follow that would make us say, you've done everything you need to do to protect yourself from colon cancer, and therefore you don't need screening. There are certain preventative factors, for example, eating a lot of fiber, avoiding eating a lot of red or processed meat that could help to lower your risk of developing colon cancer, but there's more than one risk factor, including things like your family history, genetics, and a lot of those things sort of tie in together with each other. And so there's not necessarily one factor for each patient that you can look at to say, this is one your risk factor. We sort of put the whole picture together. And I think sort of going off of what you were saying as well, it's always important to remember that our guidelines for screening for really any condition that we look for when you're coming for your routine physicals or checkups, the guideline of screening at 45 will help to capture most people who are diagnosed with colon cancer, but there will be some people who are diagnosed with colon cancer before the age of 45. And so that's why we say it's so important to look out for those things like blood in your stool, skinny poops, any sort of changes that might be concerning to you. And those are cases where we consider screening earlier than the recommended age.
All right, great. So Dr. Huang, I know you said you had a
Well, I was just going to add another way where I might get a patient to Dr. Patel and Dr. Channen earlier would be like genetic testing, because when people come in for their physicals, we always review family history. So every, and they're like, I already answered this. I go, I know, but family history changes all the time. So every year we go over it. And if we notice there's, a lot of certain cancers like ovarian, endometrial, colon cancer at a young age, we might offer genetic testing to look for like Lynch syndrome or familial adeno. I can't even say FAP.
Oh, what's this? Dr. Huang can't say a word? Oh my God.
Familial adenosis polyposis.
Good job, doctor.
So we might offer genetic testing, which is super easy. We do it right in the office. It's either saliva or blood. And if they test positive for any of those gene mutations, and even though they might be 20, 30, then I would be like, you need to go see a gastroenterologist. So that would be another way we capture these colon cancers earlier.
Okay. All right. Nice. Very good. If someone sees blood, because you guys said it twice, so I find this pretty interesting. So if someone sees blood, right, in their stool or has a persistent digestive issue, how seriously should they take this? That was actually from one of my buddies, by the way.
I think they should take it very seriously. I mean, for me, with my patients, basically anybody who mentions even a single drop of blood in their stool, I always open up the conversation about doing a colonoscopy. And especially with young patients who are under the age of 45 and maybe don't have those risk factors, usually I say something along the lines of, I think 99.9% of the chance is that this bleeding is from hemorrhoids, but there's really no good way for me to confirm that the bleeding is only from hemorrhoids unless I see the entire colon, because it's possible that someone might have hemorrhoids and also have a polyp in the rectum that's bleeding or something else going on that we should take a look at. So blood in the stool is definitely something that should be taken seriously, although I would say the vast majority of times blood in the stool is from something benign and not from colon cancer.
Okay. So Dr. Huang, you just basically made a statement that I want to go back to. You said a box, right? What was it called again?
Oh, I didn't talk about that yet. The Cologuard.
No. I'm saying I'm not saying right now. I'm just saying in general. When we were discussing, you said something about a box.
Oh.
So in my head, which I was going to ask, and since the doctors are here, could you just go in the box?
Poop in the box?
Yeah, poop in the box. Or is that
it's not ideal.
Not ideal.
What we would say is that getting screened in one way or another is the best thing to do compared to not getting screened. Now, the vast majority of patients have a lot of apprehension about the prep or the procedure, and the prep has gotten better. It's not perfect. I mean, we have many different ways of prepping for colonoscopy. And the procedure, patients are usually, for the most part, if they choose to be asleep for the entire procedure, they can choose to be awake. I mean, the procedure, for the most part, is completely painless.
Who wants to be awake for that?
Well, there are actually,
people,
I mean, like culturally, it's
Really?
very common for other people, like in other countries, to be awake for colonoscopies. Here, I think we sedate the vast majority of our patients. And But I would say that the barrier to do a colonoscopy, or there's a lot more apprehension about it than what is the reality of it. Now, colonoscopy is the best and most effective way of screening for colon cancer. It is also the only diagnostic and therapeutic way of treating precancerous polyps. The main distinction here is that a lot of these tests are really good at detecting cancer, right? There's there's a lot of different types of stool testing. There's also colonoscopy, but the only way to remove the precancerous polyp, the polyp that is going to turn into colon cancer, is by colonoscopy. So if your Cologuard test, which is a stool DNA test, is positive, well, you're still going to need to get a colonoscopy, right? If your fecal immunohistochemical testing, which is a FIT test, if that's positive, you're still going to need a colonoscopy. And there could be a lot of false positives, and a lot of those tests will also miss precancerous polyps. So while they're excellent at detecting colon cancer, they're not really good at detecting precancerous polyps that are going to potentially turn into cancer.
So I find interesting is because I had this situation with my heart, and they basically stated to me, I had to do a genetic testing. And in the genetic testing, they said to me, we're hoping it's positive, which is bad. But if it isn't, you still got to go do this. Is that the same way with that box thing? Just because it shows up negative,
it gives you a false sense of security.
yes.
Yep. Mm-hmm.
So, and I remember you said that they no longer, to Dr. Huang, that doing the finger in the butt really isn't, well, I didn't know how to say it. Digitalized, whatever you call
digital
it.
rectal exam.
Yeah, really, you can't validate that with that, correct?
Yeah.
Yeah,
We-
you should
we
still
don't
go get a
do-
colonoscopy.
Yeah, my fingers are like this.
Yeah, because you got little fingers, but maybe
And
they
I
got longer
think
fingers.
what you just said about giving a false sense of security is definitely something we see as gastroenterologists a lot. I mean, we see a lot of patients who maybe have done either Cologuard or some other form of stool-based screening and then come to us for another reason. Maybe they're having some abdominal pain or nausea or some other symptom that they're looking into. And we end up doing a colonoscopy anyway. I think of one recent patient, for example, who had a negative Cologuard that would have been up to date. He would have been due for another one maybe 3 years from now. We ended up doing a colonoscopy because he was having some other issues that we wanted to address. And basically his entire rectum was a polyp. And I ended
Oh
up
my gosh.
referring him to my colleague, Dr. Patel, who's an advanced endoscopist and is really skilled at removing these very large polyps that are high risk to become colon cancer in the near future. And, this patient, based upon the stool-based screening that he had, would have sort of gone on with his life the next few years, assuming that he was safe and protected from colon cancer. And had we not decided to do this procedure, then, we wouldn't have been able to detect that early enough to prevent him from developing cancer. So I think we have seen enough cases similar to his where we say to ourselves as gastroenterologists, like, those stool-based tests, they're good for some people and in some situations, but for a young, otherwise healthy person who's looking to really prevent issues down the line, a colonoscopy is a way better option.
Well, that's great that you did that and you
I was
agreed to
gonna
that.
say,
That's awesome.
congratulations on that find. That was incredible.
Wait, I have a question. So you're an advanced, what does that mean? I didn't know that there were different levels.
Yeah, so I wouldn't call it necessarily different levels. I mean, when we do a 3-year gastroenterology fellowship, you have the option of specializing in something in more detail. So some people do a 4th year fellowship, and so there are a variety of them out there. One is like inflammatory bowel disease, if you really want to specialize in that. One is liver-based disease, and there are people that really enjoy like therapeutic endoscopy or interventional endoscopy. And so, like I did training in that, which is, you do high risk polyps. You also you do a lot of pancreas and bile duct disorders, do a lot of pancreatic cancer screening, pancreatic cancer biopsies. And so the invasiveness of some of those procedures is greater, but the therapeutics of what we can offer within just GI has expanded quite a bit. And so now there's a subspecialty within gastroenterology that focuses on some of those therapeutic advancements.
Oh, that's cool. I didn't know that. And I think you just mentioned something that we forgot to touch base on. You said inflammatory bowel disease. So people with Crohn's and ulcerative colitis are at higher risk too, right?
That's correct. Yeah.
Yeah, absolutely. So for patients with Crohn's and ulcerative colitis, particularly those who have had inflammation involving a large portion of their colon throughout really any time in their life, we'd recommend more frequent screening, usually about every 2 years or so, sometimes even sooner, depending on what we see. But those are certainly a subset of patients who are considered to be at higher risk.
Mm-hmm.
So one of the things that you had said, both of you actually, was 45 and is now it's dropped down. So my question is, we are hearing about colon cancer in younger adults more than before. And I know you had touched some bases on nutrition and stuff, but why is it? It just seems like it's really happening. Everybody I know now is getting some issues with colon stuff, like going on, polyps, cancer, all this. Like, what's changed in today's society that's causing this?
I would say, and you guys can chime in, like maybe some of the foods that are more processed, the changes the bacterial flora of our intestines. So there's more inflammation, and then like more toxins are being released. So it's like a more hostile environment, I would guess. That would be my take on it.
Yeah, I mean, there's definitely some data on like microbiome analysis, and they've identified that there are certain bacterial species that are more prone to be inflammatory, potentially have a higher risk in developing colon cancer. Like those studies have not been completely elucidated. We do think that diet's a big factor, and we think that diet is a big reason why even within the Western world, the United States is almost like leading the charge in an increased risk in digestive health cancers overall. We process our food a little bit differently. The population tends to eat more processed food. We tend to have a less fiber-rich diet, as Dr. Channen was saying, and we tend to have a heavier population. And we know that all those individually are independent risk factors for colon cancer development. As combining all those things, which is what typically is true for most of our population, it really augments the risk of colon cancer development. And so it's hard to say that there's one specific thing, but we do know that the way that we eat, our patient population, and the fact that we in general choose low fiber foods, that those are all risk factors.
Do you think that in the Western world, because we use antibiotics, maybe we're quicker to use antibiotics, that also is changing the gut flora a little bit?
We definitely think that the antibiotic use, especially the use of broad spectrum antibiotics, which everyone, if they have a cold, they rush to get antibiotics.
Yeah,
exactly.
My pet peeve.
That definitely changes the gut microbiome. The data on whether that in of itself changes it to a more inflammatory bacterial state, I'm not 100% sure whether that's been completely elucidated. But the microbiome is the new hot topic in GI, right? We know that it not only affects gut health, but it can affect mood and other diseases as well.
So I think going off of what Dr. Patel was saying, inflammation and like obesity, just anytime we have obesity and like increased weight, it just causes inflammatory process and it just increases your risk of any type of cancer.
Okay. So how many times a year do you get a colonoscopy?
How many times a year would you like one?
Listen, I've had maybe one in 10 years, 11 years.
It sounds like you're due.
No, they told me I'm golden. They said I'm clean as a whistle. I don't even have polyps.
We'll
Did
give you
you
our card.
Yeah.
We'll give you our
You
card.
didn't know we're doing it right now.
No,
Do you want to experiment with the digitized?
No, the truth is it's very individualized for each person. And so usually I think, our practice is at the end of each procedure, we make a recommendation based upon what we see that day. And there's a lot of things that play into it. A lot of the things we've talked about, like how high risk the patient is based upon their personal and family risk factors. But we also make decisions based upon the number of polyps that we see that day, how big those polyps are, sort of what they look like. Also, the prep quality has a lot to do with our recommendations as well. So whether or not we're able to confidently say that we got a good visualization of all the colon mucosa. And so for the most part, if somebody comes in and they're average risk, they have no symptoms at all, they're feeling good, and we find nothing and everything looks perfect, we would say come back in 10 years. But I think a lot of us have a hard time giving that recommendation to come back in 10 years because a lot can change in that time. Although we think that we do a very good job, there are a small proportion of polyps that will be missed on each colonoscopy. And so,
Whoa, go back. Well, what do you mean when you do a colonoscopy, you could miss something?
It's possible. I mean, we do a very good job, but there are polyps that could be very small, potentially flat polyps that might be hidden behind some stool that's remaining in there.
Different types of polyps?
There's a lot of different types of polyps that we might find, and we can sort of go into the different types of those. But yeah, there's always the possibility that although we're very good at our jobs, we're not perfect, and so there's a lot of twists and turns in the colon. There's folds where things can hide behind, and so although we detect the vast majority of polyps, small ones might be missed, and so we know that within those 10 years that go by, it's possible that something new might develop.
So I'm sorry. This might sound like a ridiculous question, but it's a question for me. how long is your goddamn colon? You're saying twisted bounds. I'm thinking to myself, it's up to my belly button. We're good to go. You're saying you're going a little further than that?
We're going far. So our
But,
colonoscope
whoa,
that
whoa,
we
whoa, I
use.
love how easy you said that. That's messed up here. What do you mean we're going far?
So I would say with our colonoscope, by the end of the procedure, once we've reached our destination, we probably have about like 80 to 90, somewhere between like 70 and 100 centimeters of scope within the
3.5
patient.
feet.
3.5 feet?
But I mean, the colon
It
is
goes like
longer than
this.
that. So the colon.
I didn't know 3.5 feet of tube goes up your butt.
Yeah, I mean, the colon's like an accordion, so like it can expand and contract, and so our goal is to get to the end as tight as we possibly can. Like the accordion is completely compressed, but I mean, there are patients, especially patients who've had, constipation and other, colonic issues, that they will have longer colons. But the colon is long; it's a lot longer than what most people think. And so when
3.5 feet.
Yeah.
But how long is the colon? And are you going far enough?
Oh my God.
yeah, so we go to the
I
end.
just want to. I'm confused now. I didn't know it was that deep in there.
Yeah, so there are landmarks that we look at when we're doing colonoscopy to ensure
What, like
that we
stop signs?
it's close to a stop sign. So where the appendix comes into the colon, that's one clear demarcation that we've made it to the end, because that's in the first part of the colon. You can also see the valve that connects the colon, which is the large intestine, to the small intestine. And so, those are two landmarks that we really look for to make sure that we've made it to the end. And
Was that a pun?
Yeah.
Like a pun. It looked like you were doing.
Oh, I like that. I like that.
I did not do the pun.
All right.
Actually, you
That
mentioned
threw
you
me
said the
off.
word digitize, which made me think like
So
you guys do
your finger's not
capsule
doing anything.
endoscopies. That's only for upper, right? Does that go all the way to the bottom?
It's for like small bowel. So
Okay.
they've made colonic capsules before. Those are not really done that well because they're better screening methods. But capsule endoscopy in the conventional form that we think about it now is for small intestinal evaluation. There's
Okay.
20 feet of small intestine that we don't see that well.
That's where you swallow a pill with a camera in it.
Exactly.
But regarding the question of a digital exam, there is something that exists called CT colonography, which is sort of similar experience to having a CAT scan, which looks a little bit more in depth outside the colon to detect things like polyps. And it's not usually a first line screening that we recommend. There's a very, very small subset of patients who, when we're doing a colonoscopy, because of all those twists and turns, or if patients have had surgeries or certain anatomical differences that make it difficult for us to make it all the way to the end of the colon, or if we feel that we're not able to visualize everything, sometimes we will have patients get that CT colonography afterwards to get a better picture at those pieces of the colon that we weren't able to see from the inside.
Ooh, sounds scary. Ah.
I think at the end of this, we're booking you for a colonoscopy.
Yeah.
I was just
He's
scolded.
my
I
designated
was
driver.
just scolded.
He
I was just
drives.
told I listed the wrong doctors.
What? By
I
who?
don't know on the beginning title, but I'll fix it.
Oh. Okay.
This is why. All right. So, what lifestyle habits increase the risk of colon cancer? Alcohol, the way you eat, the way
Smoking.
you don't eat, smoking, not smoking. What?
We definitely know that smoking is a big risk factor, and we know that red meat and processed food are clear independent risk factors, and that we have some data on. The other diet, I mean, we think that fiber contributes. I mean, fiber is really important for colonic health, but whether it immediately will influence your individual risk of developing colon cancer in your lifetime, that's not completely understood.
I think that's one of the most common questions we get after a colonoscopy when we tell a patient that they have polyps is, what could I do to prevent this? And usually I tell patients just really not to be too hard on themselves, because there's really not all that much they could do that would make me say, you never need to have a colonoscopy again. So I think just, focusing on leading a healthy lifestyle, being active, eating as best you can, and just keeping up to date with your primary care, paying attention to your bowel habits, and coming in for screening when we recommend it is really the best thing you can do to prevent yourself from getting cancer.
Do you think pro and prebiotics could help with the microbiome situation?
I mean,
Maybe.
I think that's a loaded question, because I think that there's a lot of data on the benefits of having a good microbiome. the data on whether probiotics or prebiotics directly influence that more than diet and exercise and avoiding antibiotics unnecessarily, I think that data is a little bit mixed. I mean, we do use probiotics in very select populations. I tend to use it in patients who've had recent antibiotic use, patients who are immunocompromised, and in some patients who have like bacterial overgrowth, maybe there's some role of using probiotics in those patients, but I don't empirically recommend probiotics to every patient. Especially, I mean, there are a lot of probiotics that are extremely expensive, and you can find a lot of those bacterial species in some of the food that we're eating naturally as it is.
And we have a hard time with a lot of the probiotics, just in terms of recommending, for example, one versus another. Patients will say, which is the best one? What is the dose that I should be taking?
Refrigerated, non-refrigerated.
Yeah, and there's really not a lot of good data to direct us in one direction or another. So patients will often find a probiotic that they feel helps them a lot, in which case I'll say, great, keep on taking it. But I think many say it just ends up being expensive and not really something that they see a lot of benefit from.
It is expensive. We'll agree with that one. So one of my other questions are going to be, you ready?
We're ready.
Are you ready?
Nah, because I'm trying to figure out, because you know how I write. So I'm trying to figure out, okay, let's switch it up. What percentage of colon cancer cases are genetic versus lifestyle?
It's an interesting question.
I know, but I was thinking what they had said, and now I'm wondering.
But it doesn't change management. You still have to
I
get
didn't
your
know that
colonoscopy.
anyone would necessarily be able to answer that question 100%. Because when we diagnose colon cancer, it's not as if we necessarily go looking for what was the cause of it. And there's probably more than one factor in each person. So I think I would have a hard time answering that question with any sort of like specific numbers.
See, I told you it was a hard question for me. I
Yeah.
was like, does it
But
work?
it doesn't
it?
forego the fact that they should just get screened.
So the number one fact of it all is simple things that people can start doing today to protect their colon is what? You said nutrition, stop smoking.
Right. Exercise. We know that. I mean, like
Maintain
Dr.
a healthy
Channen was
weight.
talking about. Yeah.
Yeah. So that's that was a question that was asked, but since we already know that.
And I think also just sort of paying attention to your bowel habits. I think a lot of times people just sort of go about their day not really thinking about either like what they're eating, what's happening. And so just like taking a few moments to think about your bowel movements, look at them, see what they look like, pay attention to if there's changes, because some people probably aren't paying much attention to that.
Okay. All right. So Dr. Huang.
Well, wait, what was the question? wait, what was the question before that? Was it what percentage were genetic or? Oh, okay. Well, I think I was thinking of something else because you were saying like what kind of lifestyle factors, right? But I was thinking more of like when someone comes in for a routine physical, other things that we could look at. So like FAP, the familial adenomyosis polyposis. Adenomatous polyposis. There's like certain like physical findings, like if they have like a lot of like osteomas, like bony growths or like desmoid, like skin things, like that might be an indicator that
Is there easier words I could understand?
Yeah. There's still
sorry, my people.
like extra growths on them.
Oh, okay.
Yeah, like on the bone or the skin,
All
like
right.
stuff like that. So that might be an indicator that they could have that condition. So maybe that's another thing that would prompt you to get screened.
I would like to bring in something. So I worked the prison system for many years. I worked at Walpole Prison. And what I tended to see was nothing happening to the residents of the location, but everything happened to the officers. The amount of cancer, colon cancer and all these things, does stress come into a factor on this? Does stress have anything to do with this?
Stress can certainly play a role. I mean, we know that when people are stressed for prolonged periods of time, their immune systems are weakened, and that can certainly play a role in cancer development just in general. So while it may not be necessarily the direct cause, stress is certainly a situation that for prolonged periods of stress on the body can definitely put people at risk for increased cancer risk, generally speaking.
Okay, how about the famous thing where race isn't a factor? So is race a factor in this?
Race is definitely a factor.
Really?
And so we know that African Americans have a higher propensity of getting advanced colon polyps or colon cancer. And so sometimes, I mean, there were thoughts before that we'd screen that specific population at an earlier age compared to the general population. So that, I think Hispanics have a slightly higher propensity of having colon cancer compared to Caucasians. South Asians previously were thought to have a decreased colon cancer risk compared to the Caucasian counterparts.
I don't see them getting sick. They eat bushes and berries. These people don't eat anything. It's like they don't even, no offense. You ever go to an Asian restaurant and see them eat their own food? No, they get white rice, chicken. They don't get none of that fungu, all that. Just saying, General Gao. Who eats General Gao?
There is no such thing as General Gao in Chinese.
There you go.
China, so anyway.
It's Dean's
I know,
favorite.
or crab rangoons.
But it's a good point, because whether that has to do, we know there are like genetic differences and differences amongst races and different cultures, and whether that is genetics or if it's because culturally people are eating differently. There's a lot of different factors that can sort of play into that.
So as a primary care doctor, maybe in the back of my head, should I be like, oh, an African-American patient, or what? I should have that conversation. But the thing that there's a discrepancy, right, with insurance coverage. So because, then that's where, it stinks when we have recommendations and we have these great ideas, but then if it's not covered, but
I think that's one of the things that we have the advantage of as gastroenterologists, is we can usually find a way to get these procedures covered. And so I think as a primary care physician, if you have a patient who you feel should get colon cancer screening or a colonoscopy for one reason or another, and you aren't sure either how to get it covered or the best way to approach that, then you can always send them to see us in our office, and we can meet with them and sort of piece out what some of those factors might be, and then sort of order the procedure ourselves and work with the insurance company. Because I think sometimes we have a little bit better luck getting it covered than primary care.
oh, that's fantastic. That's good to know.
I think a lot of people have hesitation, when they talk to their primary care doctor, they're, talk to you and they're asking, or you're telling them to get their colonoscopy scheduled. A lot of people have misconceptions of what that process entails. And so I think one of the things that we should definitely address in this podcast is what is the process? Because I think that one of the things I was alluding to earlier is that people have this idea that this is a highly invasive. I mean, you were thrown back by the fact that this is a 3.5 foot scope that's going through you. But to be honest, like it's a painless procedure. The whole procedure itself takes 20 to 30 minutes. Patients come in typically 30 minutes before their appointment. That's variable based on the institution that it's getting done. They can, there are different types of sedation that are offered, and patients are booked for a specific type of sedation on specific days. If patients have preferences, we're able to accommodate those preferences typically beforehand. And then they're usually out 30 minutes after their procedure is done. The whole process, on average takes about an hour and a half. And so, for an hour and a half for most of the time, you're taking a nap, right? You can undergo a life-saving procedure that potentially can reduce your risk of colon cancer quite dramatically. I mean, it's the only way to remove precancerous lesions. And so
I
think
how you said that, life-saving.
And I think one of the things you had mentioned earlier as well, the vast majority of the world does not offer patients sedation for these endoscopic procedures. And that's because they really are not painful procedures. It might not be the most pleasant experience of your life, but it's something that can be done very easily with no medication at all. And I have some patients who have chosen, just because they prefer not to receive sedation or they want to be able to drive themselves home afterwards, and we'll do the procedure. They're awake the whole time. We're chatting. I play music. They're able to watch what's going on the screen. And really, I think the vast majority of those patients come out saying that it was a pleasant experience. And I think a lot of it is the expectation that you set advance. So if you tell the patient that it's not going to be that bad and you sort of walk them through what to expect, I think the vast majority of people walk away saying it wasn't as bad as they expect. And I usually say to my patients, like, I've never regretted doing a colonoscopy, but at least once a day, I say to somebody, wow, I'm really glad we decided to do that. So I think although there's a little bit of hesitation going into it, and it might be maybe unpleasant for an hour and a half or so, everybody is happy that they did it.
Awesome. Well, I've completed my questions and things that people wanted to know. So now it's free for whoever you guys want to discuss. And
are there any questions? I didn't put my glasses. I can't see
I've
that.
been scolded. People are just saying I'm on, hello, and being scolded that I spelled the name wrong. And that must be Dr. Pfeffer, and it has to be him.
Well, it's Pfefferman.
Pfefferman. Isn't that the guy that lost to you doing a plank and he couldn't show up today because he was embarrassed? I believe that was him.
That is him, yeah.
That's the one.
So what hospital I noticed, where is it you guys are at?
So we are part of Digestive Health Associates in Stoneham on Montvale Avenue. We cover
The same building as Jerry, where you met Dr. Pepper. 92 Montvale.
Shout out to my attorney, Jerry Griffiths, in the same building. If you get arrested, go to floor 1. Go ahead, sorry.
Also on floor 1 is our endoscopy center on 91 Montvale Avenue.
Oh,
And then-
91. That's
Oh,
right.
91, and then on the second floor is our office. We also have privileges at Winchester Endoscopy Center in Woburn, and then also cover Winchester Hospital as well in Winchester.
I have a question. I have a question for, do you guys want to talk about like when people would have to go to the hospital, like the people who are at risk, like with sleep apnea and things like that?
Yeah,
Yeah.
so we always risk stratify our patients
You
in
know,
terms
sleep-
of
sleep apnea. I'm healthy as heck.
Okay.
many people have sleep apnea and are otherwise healthy. But we do always
If
sort
everyone
of
can see my face right now, you know what I'm doing.
we
Ooh.
do look at each patient individually and sort of see how is their health generally speaking. Do they have a lot of cardiac issues, pulmonary issues, or things that might put them at high risk for complications, mostly related to the sedation more so than the procedure that we're doing. And so we're able to sort of make that decision if we can do a procedure in the outpatient setting, meaning that they come in from home, we do the procedure and they go home that day, versus do we need to do a procedure at the hospital on an outpatient setting where we have a little bit more resources available should there be a complication. Or sometimes we have patients actually admitted to the hospital where we feel that they need to be sort of monitored a little bit more closely. So we're able to get this procedure done for patients of all health one way or another.
Okay, Omni, thank you so much for asking a question. So does every culture have to eat differently, or is there a particular diet that all cultures can benefit from adapting to prevent such issues?
High fiber food. That's what they've been
high
doing.
fiber.
High fiber,
clean,
like
less processed.
You don't have to be vegetarian, but veggie like forward, I think, is helpful. And then we know that red meat and processed meats, charred meats, are at a higher risk of creating colon cancer as well. So I think fiber is usually the main thing that we really promote. And then not only does that help colon cancer, but it helps like colonic health, colonic tone, it helps improve bowel movements. I mean, there's a lot of downstream effects of having high fiber.
So I would like to add on to that because I think I understand where Omni's going with it. So I've been trying to research this and I can't find it. So I always try to go things by culture and race. So I always try to look into, so for instance, I'm Cape Verdean. So I look at my food and I look at my history of my people, and I tend to find out they suffer from glaucoma, a lot of them. So,
You mean glaucoma? The
glaucoma?
eyes?
Yeah, it's not glau.
Glaucoma.
It's glau.
Sorry.
Hey, I said it wrong again. Glau. That's all good. My people know. But so I always wonder if you stick to your own race food, does that minimize disease? Because it was interesting that you brought up Asian and how they culturally eat, and they have less findings of it. So if you go and you break it down like Mediterranean foods and things like that, and you're from Latin race, does eating your cultural food might help out?
No.
Okay. The answer is no.
No, yeah, it's not.
I think that's the short answer.
Yeah.
Okay. All right.
I mean, a
all right.
Mediterranean
Yeah.
diet is very healthy, but it's not necessarily because that's a specific culture. It's because they tend to minimize fried foods. They have a more of a fish forward diet, vegetable forward diet. It's not necessarily that is the specific diet, or the culture is that's a diet for that culture that creates the benefit. It's the foods that they're eating, right? So they're eating a lot of vegetables, they're eating lean meats, a lot of fish. They're using olive oil as opposed to maybe some seed-based oils. They're using less inflammatory sources of protein and vegetables. And so I think that is inherently better for the gut. But there are cultures and diets that may be more focused on fried food, and that will obviously have a higher risk of, those patients will have a higher risk of obesity, then metabolic syndrome, a lot of other downstream health effects from that.
So Robbie, no, not switching from McDonald's to Wendy's makes you lose weight. Does not save you either when you get the extra salad. Go ahead. Sorry.
It looks like there's a question on from Caitlin Phillips.
Caitlin, how can you see that?
I know.
good?
What's your
Wow.
favorite part about being GI doctors? Do you want to go first?
I think she probably wants us to say all the wonderful nurses that we get to
Oh.
work with. No,
That's
but I
amazing.
think
It
actually,
was a
like,
setup.
well, I do really think that colon cancer screening is one of my favorite part of being a GI doctor, apart from what I was alluding to a little bit earlier about just working with women and talking to them about like issues that are a little bit more sensitive regarding their bowels and things like that. But I really do feel good at the end of every day that, even if all I did that day was take out a few polyps, I can go home knowing that I prevented that polyp from becoming cancer. And so I think we have a really satisfying job on a day-to-day basis where we can see a problem in front of our eyes. We see a precancerous lesion, we remove it, and we prevent that risk from being there. And so I personally get a lot of satisfaction from that.
I would echo a lot of those sentiments. I think it's really rewarding to be a part of a profession that is making clear, tangible change in like patients' prognosis and their longevity and reducing the risk of colon cancer. And at the same time, you work with people that are very like-minded. So to Caitlin's, to her point, I think we work with a great set of people, and we're all doing something to help promote health and well-being in the general population. There are very few people that get to say that we've really reduced a cancer risk by doing this specific intervention all day. It's a rare opportunity to have.
We're obviously biased, but we think colonoscopies are the best test that exist in really all of medicine.
I have a question. So, I've had 3 colonoscopies, and they were all with fentanyl and Versed. So I never knew about like propofol and stuff. And then like, I guess last year Blue Cross or some insurances changed, they're like, oh, we're not going to cover propofol. I was like, what's the big deal? And then all my patients are freaking out. They're like, oh my God, I can't do it without propofol. I'm like, I really don't understand. And then in Asia, I had an upper endoscopy with no sedation, and it was totally fine. I haven't had a lower, but like, what is the big deal? Like, and is it a big deal?
I think a lot of the big deal of it is that expectation setting with patients. I think we want to do our best to be able to say to everybody, we are going to keep you perfectly comfortable. You will be asleep throughout the whole procedure. And that's most easily achieved with propofol. But in order to safely perform the procedure, we don't really need that. And so I do think the vast majority of patients, if you give them the right expectations going into it, can do the procedure without any discomfort with that moderate sedation with Versed and fentanyl. We actually see probably the most challenging group of patients to sedate are younger people who are actually pretty healthy, drink alcohol on a regular basis, use marijuana on a regular basis. Those are usually the patients who we have a harder time getting comfortable with that conscious sedation type of style, and usually have a better chance with propofol. But the vast majority of patients will do okay with conscious sedation. I'm having my first colonoscopy in a couple of weeks, and that's the sedation that I chose.
Very exciting. I have to say, it's the best sleep ever. I love it. I always go first thing in the morning. I want to be the first one. So I'm in and out. I go home. I sit on the couch and watch Netflix.
Yeah, it'll be a great day.
I love it.
No comment.
Oh.
Well, he's up for one, so we'll get the book next week.
The best part I took away from where your office is, you're on the first floor.
Yeah.
So that means if I have to run in there and something happens, it's just on the first floor.
Yeah.
That's what I heard.
You mean if you have an accident from the prep?
Exactly. It's on the first floor. All right. Anything?
I don't think I have any other comments. I mean, I think we echoed a lot of the sentiment already. Is that colon cancer screening is imperative. I mean, it's really important. It can be life changing for a lot of patients. The number of precancerous polyps that we're detecting it's just rising as time goes on. And so if we can get these precancerous lesions out before they turn into something more concerning, and we can do it in a safe, easy procedure that is relatively painless for the majority of patients, there is no real downside to this. And I think what I would say is that if you are a loved one, is 45 and has not been screened yet, definitely get screened because it can be life changing.
I think one of the other things that we really haven't talked much about yet also is that colon cancer is treatable. And so when we do find it, although we're not hoping to find cancer when we're doing these colonoscopies, when we find it, we are happy that we found it because the vast majority of these patients are very easily treated, sometimes with just a surgery or, sometimes surgery and then some sort of treatment in addition to it. But when we do find colon cancer, it's usually something that we're able to set patients up for treatment for. And so it's really just important to detect these things as early as possible.
And I have a question for the gastroenterologist. So, the guidelines, the United States Preventative Service Task Force, USPSTF, says screening can stop at 75, but I feel like I have a lot of healthy patients that are beyond 75. I would say that they should continue with their screenings. What would you say?
Yeah, I think that that's very reasonable. I mean, we do it, case by case, but I'd say in general, patients are living longer than they did before. Some of these guidelines were initially implemented when we thought that there was 10 years of reasonable life expectancy left. And so if somebody was 75, we look at population statistics that maybe at 85, they're not as healthy and robust. But now we're seeing patients that are older and older and doing really well from a cardiovascular standpoint. The other thing is that, looking at their history, right? So if they've had no polyps ever, they've had 3 or 4 colonoscopies, they're 75, and they're like, well, I really just don't want to get another one. They probably don't need one at 85. But if you've had polyps, which, over time, a lot of patients will have polyps and they have a family history. And those patients, and we know that over time, the risk of colon cancer goes up, right? So while it is high in patients in their 40s, it's even higher in patients in their 70s. And so if they're physically fit and they have reasonable life expectancy and they can tolerate doing a prep, I think it's a very reasonable thing to keep going on with. I mean, I typically, in low risk individuals, stop at the age of 80. And in patients, there are a lot of my patients that say, hey, I've had some small polyps a long time ago, but I'm robust and we'll do it. It's case by case.
What's the oldest person you've done a colonoscopy on? Was it 80?
No, we've done patients in their 90s, low 100s.
Anybody.
That's if a lot of those patients are coming in with some sort of symptoms. But from a screening standpoint, probably mid 80s. You may have done it later than that. But.
Yeah, I mean, really, there's no age at which we would say you are too old to have a colonoscopy. It more depends on some of those other health factors. I do think, just a little bit what we were talking about earlier, the patient you just described who is maybe getting to be 80 years old, has had a number of colonoscopies and has never had any polyps. That might be a patient who you might say that the stool-based screening might sort of help them decide whether or not they want to do that 4th colonoscopy when they're sort of getting to be later in life, and that procedures might be a little bit more high risk versus the patient who's earlier and younger. You really want to get them in for that colonoscopy. But I agree with that sort of 10-year life expectancy. So we don't really cut people off at any specific age, and neither does insurance. We're always able to get these things covered.
We have a comment.
Comment.
Knock me out, or I'm leaving.
Oh gosh.
And that's okay. A lot of patients share that sentiment. I mean, the trend over time has been that we do more cases with anesthesia, which is propofol, where you're completely asleep. It seems to be a trend within the States where patients want to be completely asleep, and we can accommodate that. And a lot of places can accommodate that. That's an expectation that if that's what your expectation is of the procedure, you should make that very clear to your referring provider and your gastroenterologist so that we can book you on an appropriate day. And we do days where we have conscious sedation. We have days where we have anesthesia. It is very hard on the days that we don't have anesthesia to get anesthesia because we just don't have the anesthesiologist at the time. And so just making sure that we know what your expectations are. So if you're calling to schedule your colonoscopy, you're like, I really need this type of sedation, or I don't want any sedation, or I don't care, then it's important that you make that preference known.
So there's a rising trend in the use of GLP-1s. Do people need to stop it because this is lower track? Do they need to stop their dose 1 to 2 weeks beforehand?
You'll get different answers depending on who you ask. And some of this has a little bit to do with, our guidelines that we follow versus the guidelines that our anesthesiology colleagues follow. And the reason that they do often recommend holding these medicines prior to procedures with sedation is that these patients have decreased gastric emptying or delayed gastric emptying and often have a higher risk to aspirate if there's food in their stomach during their procedure. We in the GI world feel that this risk is fairly low compared to patients who are undergoing larger procedures. And so we do have to make that decision a little bit with our anesthesia colleagues. Generally speaking, for elective procedures like a screening colonoscopy, we do ask patients to hold those medications in advance. For something emergent or urgent, we would not delay the procedure for that reason. But I think those things will change a little bit within the next few years.
So maybe I didn't understand. So if you get Versed and fentanyl, there isn't an anesthesiologist there, right? That's only with the propofol.
Correct.
Okay. So because you said that, you consult with them to make that decision. But so if they're only doing Versed and fentanyl, does that change, or you still would advise holding off on the GLP-1?
We still, the guidelines are evolving. The AGA or the GI Society has one set of guidelines, and the anesthesiology guidelines are a little bit different. And so what we've adopted at this time is that, depending on the type of medication you're taking, we ask for screening procedures for it just to be held. For, if it's a standard GLP-1 like Mounjaro, Ozempic, Wegovy, Zepbound, those are the 4 most common ones that are used. Those we ask patients to hold it for a week. That guideline may shift, but it's because there are patients that are scheduled for days that may be with anesthesia, days that may not be with anesthesia, and so it's just important to make it clear in our instructions and for ease of scheduling. It's we have this general guideline.
Okay, that makes sense.
I appreciate that. That was good. Very good. Very good. Any other questions? If you were to say something, what would you say at the end?
Call us if you're interested in screening.
We're looking right at you.
Prevention is key.
Prevention is key.
Prevention is key.
Yeah,
I love
but
that.
I'd like to share a story.
Prevention is key.
So we always want to be ahead of it. We don't want people coming in panicking, like, I need a colonoscopy now because I'm bleeding. So I'm guessing this patient is probably watching, but like she's 47. And and at 43, I was like, okay, let's start talking. We're going to do, colon cancer screening at 45. And then at 45, nope, I'm going to do a Cologuard, and got the box, didn't do it. Then she came in yesterday in a panic. She's like, I think I have colon cancer because I have bloating. I saw blood in my stool. And she's like, I need a colonoscopy now. And I'm like, well, you're 47 now. We started having a discussion like 4 years ago. Like, what happened then? Like, let's be preventative. Preventative
is key.
Yeah. Prevention.
Correct. Prevention is key.
Yes.
All right. Well, I really appreciate this. I'm not going to lie. I found out my colon was much longer than it really was. I found out you're going a lot deeper than I expected. Now that really is going to throw me off for a little while. I'm not going to lie. But if you, outside of saying to prevent it and everything, you guys have said your practice is in Stoneham. So once again, you guys know how it all works. I understand a lot of you just can't watch it live and then later on catch it. But if anyone wants informative information and basically would like to see them, the 2 doctors, I will provide their information when I put the names correctly, and I do sincerely apologize for that. I don't understand how that happened, but I will put the information on. And then if anyone wants to get the number, the location, and the emails, I'm sure they'll provide it, and I'll upload it, and you guys can take a look at it. So anything you would like to say, Dr. Huang?
Well,
because I know you like to say things.
I wanted to end with a funny poem from medical school. I thought that you guys would appreciate. So this is my first year of medical school. Dr. Ben Kamenar. So I went to BU medical school, and he did this during our motility lecture. So it's a joke about your butt.
My butt?
Well, not your butt, about butts.
So why are you looking at it?
Okay. So about that sphincter down below, it's been very important, we've been told. They say that man has succeeded where the animals failed because of the clever use of his hand. Yes, compared to the hand, the sphincter ani is far superior. If you place it into your cuffed hand, a mixture of fluid, solid, and gas, then start opening the bottom, trying to only let the gases escape, you will fail. But the sphincter ani can do it. The sphincter can always tell if the owner is alone or with someone, whether he is standing up or sitting down, whether he has pants off or on. No other muscle in the human body is such a protector of the dignity of man, yet so ready to come to his relief.
That's great.
The sphincter ani.
That is deep.
I'm so confused. There's a lot of words.
You guys like it?
Yeah, I
Yeah.
didn't
It's
understand.
basically saying your butthole is pretty awesome.
It's a very complicated muscle.
Yes.
All right. So back in the, no, I'm not going to say. All right, everyone. Thank you so much for
Wait,
joining.
there's one more.
Huh? I'm sorry.
CC.
I am with you. No, that was
Oh,
me.
knock me out. Oh,
Don't try to be like
Oh.
Dr. Your eyes are.
I
you
know.
can't
I
read,
know.
You
I know.
can't see.
Okay.
He's got
Yeah.
20-year-old eyesight. Okay. Remember how old we are. All right. So listen, everyone. I would just like to say, colon cancer is one of the most preventable cancers, as the doctors have stated, when caught early. If you take one thing from today's conversation, let it be this: don't wait. Talk to your doctors, which we had the honor to speak today on the show, and get screened and takes control of your health. So once again, I would graciously like to thank you three for showing up today, and Dr. Huang for introducing us to come on the show. And I really appreciate it. And thank you for understanding how I speak. Because I get told you say words wrong, which I did. What was the word?
Glaucoma.
Glaucoma.
It was
That's a Boston thing. It's a glaucoma. I guess
I didn't know if
okay?
it was like
Come on, you guys know what I mean. But thank you so much.
Thank you.
Thank you so much for
Really
having us.
appreciate it.
Thank you. And I am gonna fix it, Dr. Pfefferin. Oh, what? No.
His name was
Peppermint.
Pepper.
It's like
Pfefferman.
peppermint.
Pfefferman. All right, everyone, be blessed. Thank you so much. Love yous all. Don't say anything because everybody.